Welcome to Digital Health Insights within Healthcare. We've been doing these podcasts for a while and making them available on the In Healthcare website, and there's a dozen episodes in our archive, but this is the first show that will be available via Apple Podcasts and Spotify. So Jamie, welcome to the big time. So please introduce yourself and In Healthcare to our listeners first of all.
Thanks, Bernard. So hi everybody, my name's Jamie Innes, the Product Director at In Healthcare. In Healthcare are a digital health company based in Harrogate in North Yorkshire, and we've been working with the NHS over the past decade to design digital services to allow patients to be monitored in their own homes and in different care settings.
Tell us a bit about what your job actually involves, please.
So as the Product Director, I get involved with our customers and partners in developing and designing new digital services, and I also work with our development team on enhancing our platform continuously, adding in new features and functionality based upon our customer needs and also what new technologies are available in the marketplace.
Okay. So to set the scene for today's discussion, we are recording this on an auspicious day. The King has asked Rishi Sunak to form a new government for the United Kingdom. And if you cast your mind back a few months to the summer, Rishi made some bold pledges to help the NHS whilst he was on the campaign trail. So here's a quick reminder of what he said.
NHS will be safe in my hands. We face the worst NHS winter crisis in decades. Tackling the backlogs is the biggest public service emergency. We need a fundamentally different approach. We will take the best of our COVID response and apply those lessons to clearing the massive backlogs in the NHS.
So to quote, taking the best of our COVID response and applying those lessons to clearing the massive backlog. So to bring things closer to home, I was speaking to the chair of a large hospitals trust the other day who said that morning they had nearly 100 people in A&E waiting for a hospital bed and 300 people in hospital beds who couldn't be discharged because of a lack of social care. So this fundamental capacity problem will be replicated in every town and city across the country. And we know that virtual wards are supposed to be part of the solution. So Jamie, what exactly is a virtual ward and how can it help?
So you're absolutely right that virtual wards are designed to solve this problem that the NHS is currently facing. Virtual wards are really designed to support patients that would otherwise be in a hospital bed. This is typically through supporting them with early discharge, but also can be supporting patients who are at risk of hospitalisation through admission avoidance. But ideally what they're looking to achieve is to reduce the amount of bed blocking that's currently occurring within the system and to support patients in their own homes rather than in the hospital bed.
And how can you deliver hospital care at home?
It's a very good question. I think you have different patient needs and those can be met in different ways through different types of remote monitoring technologies. And the technologies are now available to provide everything across the spectrum from weekly, bi-weekly monitoring through to daily, through to more continuous monitoring that might be able to support different types of patients at different levels of care and need that they might have in their own homes.
Okay, which type of conditions can be treated in virtual wards?
At the moment, a lot of our customers are focusing on respiratory and frailty. That's because NHS England, when setting out their guidance around virtual wards, highlighted those as the initial areas for providers to focus on. That was done through a combination of expansion of some of the COVID virtual monitoring programs that had been so successful during the pandemic, but also a recognition that respiratory and falls particularly are some of the most common reasons for A&E attendances and hospitalisation.
So if you can get a handle on those two conditions, you can prevent a lot of the consequential knock-on effects that create capacity problems within the NHS.
Precisely. It was identified that those would be two potential big wins if you could start to reduce some of the attendances by patients for those two conditions.
We were both in a roundtable last week with some consultant cardiologists who are setting up virtual wards for patients with heart failure and atrial fibrillation. So what approach are they taking?
So it was really interesting having that roundtable discussion with those cardiologists and subject matter experts within the NHS. The approach that they're taking is heart failure is typically one of those services where patients are remotely monitored in their own homes, typically for weight gain, because it's an indicator that they're retaining water and therefore there's urgent action needed to be taken. What the cardiologists were talking about is identifying some patients that could be sent home earlier and providing them with some care and support and education around their condition. They were looking at identifying those patients at a relatively low risk and potentially being able to free up beds by monitoring them at home once or twice a day through simple technologies that would enable patients to take their own measurements and input them into an application or online portal or text message so that the consultants could review that information.
And how many readings a day do you think they would be comfortable with, the doctors, to be able to discharge their care?
It was a really interesting discussion because when we'd first talked to organisations about virtual wards, we were anticipating continuous streams of data going through to wall boards and consultants sat there watching these screens. But through discussion with different areas over the past few months, we've identified that there isn't an immediate need for continuous monitoring in a lot of cases. For a lot of our organisations and customers, it's about starting simple, starting with once a day measurements coming through, looking for trends and just looking for those early identifiers and indications that maybe someone's deteriorating, but also providing patients with a bit of reassurance when they have been discharged that somebody is there supporting them and available if they need it.
So NHS England has set some pretty tough targets for virtual wards. It wants 40 to 50 such beds per 100,000 of the population by December 2023. And there's talk that this deadline is likely going to be missed. So what, in your opinion, are the main barriers to adoption?
From my perspective, there are a couple of real challenges for the NHS at the moment. I think this time of year is always a challenging period for the NHS. They're expected to, reach capacity with a lot of services and receiving increased demand because of winter pressures. At the same time, they're expected to implement new services. And to use an analogy that's very famous, it's like trying to change your car tyres whilst driving down the motorway. It's very difficult to make those major changes and change, ingrained behavioural approaches very quickly. And I think that is a big challenge to adoption. I think that's why a lot of our areas are starting small and looking to introduce this change gradually and incrementally, starting with some easier cohorts of patients and then moving on to the more complex cases. I also think that one of the challenges faced by NHS organisations is, since NHS England's policy announcement earlier in the year, there's been a tremendous amount of noise in the marketplace. At last count, through an NHSN evaluation, there was approximately 85 different suppliers of virtual wards. That is very challenging for an NHS organisation to sift through and identify what is appropriate for them and what's going to meet their needs.
So 85 different suppliers of virtual wards. Do they all meet the required standards? And what do NHS organisations need to know when they're procuring virtual wards?
It's a very good question, and I think they may meet certain standards. It's, I guess, to what level they meet those standards. Through our decade of experience, we've learned how to deliver these services, and we've got lots of great experience in implementing this change about what are the bells and whistles that a lot of areas want once they actually start to deliver services. As an example, lots of organisations might talk about reporting and the ability to deliver that functionality. But what we've found is that reports are very challenging. Reports are very difficult to produce for organisations because everyone has their own different requirements, and therefore, whilst we also support and create reports for our customers, we also give them access to the raw underlying data to query themselves and produce their own reports. That's a difference in terms of functionality that's difficult to understand when you're evaluating suppliers, and you might just see a tick in a box that says, yes, I can get reports from this organisation.
Okay. Interoperability is a real mouthful as a word, but it's quite a fitting word, isn't it? Why is it so important, and why is it so difficult to achieve interoperability?
So I think that falls into some of the challenges when you're evaluating suppliers. Many suppliers will say that they're interoperable with different systems, but you find different levels of interoperability. And that's through experience, that's through delivering services over a vast period of time. As an example, we integrate with the partner APIs for EMIS Web and System 1. Those partner APIs give you much greater capabilities than what you receive through the NHS digital route of GPIT Futures, but most importantly, they cover primary care and community services, which is a big differentiator and vastly different to the NHS digital route, which only covers primary care. So if you ask somebody, are they interoperable with GP systems or with EMIS Web and System 1, you might get an answer of yes, but it only covers primary care and not community, which you might need in your organisation.
So why is interoperability so difficult for some suppliers to achieve?
I think ultimately it's time. It is vastly complicated and incredibly time consuming. There's not just a technology component to this, it's also a compliance and assurance process that you have to go through typically. That is vastly underestimated and takes a lot of resources to do it properly. So whilst the technology route can be complicated and time consuming, a lot of organisations don't appreciate this assurance and compliance element, and therefore it is vastly more challenging and difficult to implement than what they originally anticipated.
To what extent do you think that acts as a brake on innovation?
I think it's definitely a barrier to adoption, and I believe that NHS Digital wants to level the playing field, which I think is great for technology. I think it's great for the NHS to be able to deliver a single route and interface for all suppliers to use. I think the challenge with that is just timescales in terms of implementing it, and I think there's fundamental changes that need to happen in the system to allow that. But I think currently it's a bit of a barrier to adoption of new technologies.
Okay. On the question of accessibility and inclusion, what about the elderly patients, the vulnerable patients, the disadvantaged patients who don't have digital or data or the confidence to use devices? What about them?
I think one of the fundamental things that we believe in healthcare is we don't want to create a two-tiered healthcare system. We want digital health to be freely accessible to all patients, regardless of their technology that they have available to them, regardless of their location, and that's why we try and support patients with different communication channels. I believe that as part of the virtual ward programs, patients shouldn't be disadvantaged based upon what technology they have available, and that's why we're supporting organisations in being able to deliver patients that might only have access to a mobile phone and text messages, the ability to be part of a virtual ward programme, but also provide patients with equipment so that they can use the latest continuous monitoring devices if that's what their healthcare professional wants.
What's the inherent danger in building digital health services that are informed by data only from digitally engaged people?
I think the fundamental challenge that you have is you end up with skewed results. You end up with data that indicates to you that patients only use smartphone applications or only use this latest, greatest technology, maybe want to use their Apple Watches to be able to monitor their own health, and you end up with information from a small subset of individuals who maybe aren't the most frequent users of healthcare services. I think to be truly inclusive, you need to consider those individuals that aren't the latest adopters of technologies and are actually the most frequent users of NHS services to understand what they want to achieve and really what drives them to their current behaviours.
We see lots of wearable technology coming into the consumer market. Do you foresee a time when smartwatches, patches and the like will be compatible with the NHS?
Absolutely. I think the new technologies that are becoming available to consumers are fantastic. I think it's had a great impact on allowing individuals to become aware of their health and become much more engaged in terms of understanding the impact of their health on their behaviours and their lifestyle, and therefore I think this technology is fantastic, and I think it will introduce change within the NHS. I think what we need to see within the NHS is the use of pathways and protocols and processes which take the data from these consumer devices and triage it and present the escalations and deteriorations to healthcare professionals in a meaningful way. I think there's a challenge with potentially patients using lots of consumer devices that they generate more demand on the NHS, and you end up with data fatigue within healthcare professionals who are viewing lots of information that might not be relevant to them, and therefore it needs to be managed in an appropriate way. But I think the adoption of new technologies by consumers for health purposes is only going to continue to grow because Apple and Google are becoming much more engaged in this market. They're starting to introduce new consumer technologies in their smartwatches, and I think it can only be good for the general health of the population. I think what we just need to see in the NHS is the right use of platforms to be able to interpret that data and present it back in a meaningful way.
Okay. Casting back to the beginning of our discussion, the new Prime Minister in his first speech to the public today has promised a, quote, stronger NHS, close quote. As a technologist, how do you think he can deliver that in a nutshell?
I think, from my personal opinion, there's not going to be one silver bullet that's going to solve all the challenges within the NHS. I think the talk of a vaccine-style task force is a bit of a red herring, and I think what the NHS needs to focus on is about making efficiency changes across the whole delivery of care to patients. I think from my perspective, I would focus on marginal gains and improvement across the entire system that overall lead to great efficiency, rather than hoping that there's going to be one silver bullet and one challenge that they can overcome that's going to solve all the problems within the NHS. I think through focusing on that type of approach as well, it leads to better overall patient care, because you're not just focusing on bed blocking within A&E, you're focusing on how you can deliver efficiencies and you're focusing on how you can deliver great patient care across the entire system. And I think that's the approach that I would take in terms of delivering a stronger NHS with better access to technologies and more adoption of remote patient monitoring for patients.
Thank you very much, Jamie Innes. So to leave you, our listeners, with some food for thought until next time, here's a short clip going back in history, several decades, from Nye Bevan, who was, of course, the founder of the NHS, because I believe we can take inspiration from our past. So thanks again for listening, and over to Nye.
I had in mind when we organised the National Health Service in 1946 to 1958, and remember when we did it, you younger ones, this is immediately after the end of the Second World War, when we were asked, Sir Winston Churchill then said, a bankrupt nation. But nevertheless, we did these things. And there is nowhere in any nation in the world, communist or capitalist, any health service to compare with it. Now, the National Health Service had two main principles underlining it. One, that the medical arts, the science of the healing, should be made available to people when they needed them, irrespective of whether they could afford to pay for them or not. That was the first principle. The second was that this should be done not at the expense of the poorer members of the community, but of the well-to-do. In short, I refuse to accept the insurance principle. I refuse to accept the principle that the National Health Service should be paid by contributions. I refuse to accept that. I refused to accept it because I thought it was nonsense. If you hadn't fully paid up, you couldn't have a second-class operation because your card wasn't full of stamps, could you?